Hi, everyone. We have a great show today. We have Dr. Lawren Honken, your friend, the OBGYN, and we get into all things OBGYN. We talk about childbirth. We talk about STDs. We ask all the tough questions that we wanted to ask. And if you're listening with your family or your children in the car, maybe switch to another one and come back to this one later. Thanks for listening. Today's episode is brought to you by our sponsor, Columbia Family Chiropractic, with 3 easy-to-get-to locations, one in Forest Acres, which is by Trader Joe's, one in O'Neill Court by the DMV, and one in the Northeast by Sand Hills. You'll be sure to have somewhere near you. They offer a ton of services from corrective care, on-site digital x-rays, spinal decompression for bulging or herniated discs, dry needling for injuries, pediatric care, and a Class 4 laser. They accept all your major insurances. And if you mention this ad, you'll get a discount on your first appointment. Check out their website at cfc4health.com or Google Columbia Family Chiropractic. That's cfc4health.com. Hi, everyone. Welcome to Here for the Health of It. I'm Dr. Randy here with Dr. Tom, as always, and we have a great show today. We have Dr. Lawren Honken, who is known on Instagram as your friend, the OBGYN. She's a wife. She is a mom of 3, board-certified OBGYN, menopause practitioner, and integrative medicine practitioner, and she's passionate about women's health and education. So thanks for being on the show.
Yeah, thanks for having me. I'm excited.
So you're our first gynecologist on this show.
Wow.
So we're excited.
I feel very
just talking
privileged.
to 2 bros about gynecology.
Yeah,
and we have a lot of questions.
Yeah, I mean, that's,
We need it.
Yeah, that's
Yeah.
great. That's the first step, is admitting what you don't know.
So was this always a dream of yours to be a gynecologist?
No, it was not. Yeah, I really thought that I was going to be a rural family medicine doctor.
Okay.
Thought maybe geriatrics for a little while, and then I thought like rural family medicine, and then just did all my rotations, and I really liked everything. I thought peds for a little while. I liked psych. And then just, I don't know, OBGYN. I had an attending who really was kind to me and told me I would be good at it. And I think it just sometimes takes people that you admire speaking into your life and being like, hey, this would be a good fit for you. And then I was like, okay, yeah, I actually like doing this a lot. And then it was kind of everything was clicking into place, and I was like, all right, this is the right spot. So
Yeah. And you don't really have to deal with guys.
Correct. Just little ones, baby guys.
Little baby guys.
Yeah.
But it's interesting.
And husbands.
Yeah, and
I was
husbands.
gonna
That's
say.
a big thing too. Good point. And,
Baby daddies.
Well, and I feel like the OBGYN space had a lot of males for a long time.
Mm-hmm.
And now it's transitioned pretty heavily into a lot of females. And it seems to me like a lot of females prefer a female doctor. But I don't know if that's true or not.
Yeah, I mean, I would say a lot of women that I see do say that they prefer a female OBGYN, and now it's like over 50% of OBGYNs are women. But there also are a lot of good male gynecologists, to be honest. My last pregnancy, my doctor was a male, and I think it just kind of depends, honestly, on like the person and the personality, because sometimes you can get guys that are like really sensitive to women's needs and believe women and do a good job, are good surgeons. And then you can get women that are kind of like writing other women off because they're like, well, I didn't have these issues when I was pregnant. So like,
Toughen up,
so
yes.
yeah, I think it just kind of depends.
Interesting perspective.
Yeah. I would have never, I would have thought for sure of picking women if
For
I was
sure.
a woman.
I was always wondering if it was like a red flag if a guy wanted to be a gynecologist.
I mean, yeah, a lot of people think that, or like, especially have a lot of, or a couple family members that are like, why would you pick this as your career?
Yeah.
Like all you're doing is this all day, that you're like looking at someone's private parts all day. But it really, I think that's something that people don't understand about OBGYN, is that it is such a broad field. Like you get to do surgery. So you get to operate on people, obviously, to do C-sections, but we also do like hysterectomies. We do surgery, take out cysts and do ablations. And so you get to do a lot of surgery, which is nice. You also have continuity with your patients. So a lot of patients that I have, I've delivered their babies, and then I still see them for their annual exams, or I've done surgery on them to help them get pregnant. They get pregnant, we walk through their pregnancy together. Or I see patients that are perimenopausal or postmenopausal and manage their menopausal hormone therapy or any symptoms or issues that they have. But it's a lot of primary care kind of stuff too, which is nice. Like the relationship that you get, like a longitudinal relationship with patients, which is cool.
So your typical day though could be as wide as like an infant or somebody being born to a 92-year-old with stuff going on.
Yeah. So our day, and that's another nice thing about OBGYN is that it is so varied. Like you're just kind of depends on, my days usually are pretty set, but the week can be vary. So like if I'm on call for 24 hours, on call is usually going to be anybody that comes in labor, or anybody that's being induced, anybody that delivers. So I round on all the postpartum people, see any patients in labor and manage them, see any patients that come into OB triage and manage them, see any patients that come into the ER with any GYN concerns, and then sometimes see people in the office. And then the office days are going to be either seeing pregnant patients or seeing GYN patients, like annual exams or problem visits. And then I have OR days too. So then just operating all day, which is fun.
Hats.
Yeah. It like keeps it fun. You never get bored.
Yeah.
Love that.
Do you got, what are the nicknames for gynecologists? Like, is gyno an appropriate nickname?
I mean, I feel like that's an appropriate nickname. Like, like my gynecologist.
Yeah.
But also too, there's like a regional nickname. So a lot of in the South, or I guess in South Carolina, and I trained in Georgia, we say like OBGYN or we say OB-GYN.
Yeah.
But some places they'll say like OB-GYN, or they'll say my gyn instead of gyn, which is, I don't
Then
know.
you get,
But I don't really know all of the
there's any
nicknames.
other
I'm
slang
sure
out
there's
there.
some good ones on TikTok.
Like crotch doc.
Yeah. Oh, that's a good one. They all changed my Instagram handle.
Your friend, the crotch doc.
I was just thinking just like the crotch doc.
Yeah.
There might be one
There might
out
be,
there already.
Yep. Love your glasses.
Thank you.
Question about them. Or just glasses in general.
Yes.
They're not, you don't think they're prescription?
Well, no, that's going to be one.
Oh,
and
okay.
so a couple. One, do you wear like athletic glasses when you're doing surgery, like rec specs or something where you're like,
Yeah.
I'm in the zone?
Like how when you're play basketball, and you have to wear the goggles.
Yeah. Yep. You know
So
that
nobody breaks your
you
glasses.
strap like clip them in the back. And then do you change up your glasses for different things? Like say you're going in for a consult, you might go, all right, I'm going to throw on my maybe slight like more.
So I look smarter.
Yeah, like
maybe
my white lenses or something like. Do you think about that?
No, I don't really. Actually, my daughter.
You literally just use them for vision?
Yeah, my daughter picked these for today. She said they look the best with my outfit. So I was like, okay, I'll wear these today. And
Fair enough.
Yeah, they are all prescription. My vision actually is pretty bad. Like the big E when you're doing the vision test, I can't see that.
No.
Whoa.
Yeah.
I thought that was impossible.
Yeah,
I thought that was
it's
up there as a joke.
I shouldn't be driving apparently without corrective lenses. But yeah, I used to wear contacts all the time, and as I aged, my eyes just got really dry, and so my contacts were annoying, and now I just wear my glasses all the time.
Okay.
I got married, so I don't have
Did
to
you
worry
wear
about.
glasses for the wedding?
I did not. I actually haven't started wearing glasses until after. So I don't need to impress anyone.
Lots of
It's
it.
like just glasses all the time now.
When did you disclose to him how bad your vision is? Like, that's not first date stuff.
Yeah.
I
When
can't
You were
even
like
see the
railing
E.
his face. You were like, I love you. I can't see.
No, but sometimes my kids do like to, like, especially my son, for me to take off my glasses, and he likes to like hold up fingers to see like how many I can see. No, I feel like I was pretty honest about my vision early
Right.
on. Yeah.
Yeah.
Probably so.
My
gonna
mom
ask him
has
after the show.
terrible vision, And she always said that she can't hear well when she doesn't have her glasses on.
Hold on.
Have you ever experienced that? Like,
I don't know. That's good. I might try that. Maybe I'll just take my glasses off on purpose so I don't have to
hear nothing.
No, my mom said when she finally got me glasses, I was like in the 5th grade, and she didn't realize how bad my vision was. But the teacher told her, because they moved my seat, I had been sitting in the front row and I was like sitting in the back, and she was seeing me squinting like all day. And I was too embarrassed to say anything.
Yeah.
And then when I got glasses, then I could tell that the trees had like individual leaves on them, because apparently I just thought they were like puffy, like, I don't know.
Yeah.
Love that.
I don't remember that, but.
Okay.
So I'm curious who the OBGYNs beef with. Like, what other specialties?
What docs?
Yeah, I mean, I think it depends on the OBGYN specifically, but I would say OBGYNs and medicine in general have a reputation of being the kind of like the mean girls. I mean, I wouldn't say I fit into that really.
Oh.
Well,
Which-
you're dealing with women giving birth.
Yeah.
You got to come in and sometimes just.
be the mean girl, maybe. I don't know. But
probably
yeah,
it.
when
I have a hard time
decided-
picturing you being the mean girl.
Well, I don't think I'm a mean girl, but like when I chose OBGYN, because I was considering like peds and family medicine and stuff, when I told the residents like that I liked in other specialties that I'm choosing OBGYN, they were like, why?
Yeah.
Like that doesn't really like fit. But yeah, I feel like that's like the OBGYN reputation. So basically that is to say like we beef with everyone basically.
Love that.
No, I mean, I think every doctor that sees patients in the hospital and has to admit patients in the hospital beefs with the ER. So, you want to, because the ER doctors have such a broad range of things that they have to see and know. And so, and they're just trying to get the patient either out the door or figure out if they need to be admitted.
Right.
Kind of thing, apart from like a true like emergency. So yeah, ortho, everybody beefs with ortho because ortho doesn't want to admit patients. So they actually, I got a call. Thankfully she didn't end up at our hospital, but that ortho needed to admit a pregnant patient to do an orthopedic surgery on her. And they just needed to know, would I accept the patient to admit her? And I was like, I mean, she doesn't need to be admitted for a surgery for me,
Right.
but I'll be happy to check on our baby when she gets here.
Interesting.
But mostly it's just because it's a lot of paperwork essentially.
Oh, smart.
Makes sense.
I like that.
Yeah, they're smart. They are very smart. That's why that specialty is really competitive because
I feel like a lot of them are handsome too, right?
I don't know. I mean, I guess so.
Okay. I mean,
I don't really know.
you can't see.
Yeah, I can't really see them.
I like that question. What's the most handsome specialty?
And
I don't know. That's a really good question.
besides chiropractors, obviously.
Well, yeah, but that's not like that's like a whole different field,
different deal.
basically.
Yeah.
Yeah, like I feel like chiropractors and dentists are like but I feel like ortho has a pretty good reputation of being like, they're like the bros,
Yeah, yeah. Golf bros.
Some muscles.
Yeah.
Yeah.
I don't know. Yeah. They like to work out, I guess.
Fit.
I don't know. I only have eyes for one dude now in my life, so I don't really notice
That's
them.
right. Do you ever have to match energy of patients? Like when you go in and you like say they're screaming even, are you going, Becky, we got to have this baby tonight? Like if you're ready to yell?
Oh, no. I don't feel like
What's your
have I yelled?
Yeah,
I
what's
don't-
your demeanor?
No,
Are
I
you a
don't feel like
chameleon?
that.
Like you get in there and you just adapt?
I mean, kind of. No, I feel like I'm kind of always the same.
All right. Calm.
But like it depends on, I feel like what the patient needs, because sometimes the patient kind of has it under control themselves. But I guess, yeah, if they're screaming, I'm usually like, okay. It also kind of matters why the screaming's happen, because some people are going to be like screaming as the baby's coming out,
Right.
like as like a productive scream. Sometimes people are screaming because they're like scared
Yeah.
and they don't know what's happening. So then those are the people, or maybe they're screaming because they're in pain, but they're not like actively pushing. So those are the people that you have to kind of be like, all right, let's focus a little bit and focus on
Yeah.
pushing, channeling this fear and pain and energy into your pushing and not into like screaming and losing your mind.
Yeah, I was wondering clinically, is there anything screaming helps with? Like,
I don't know.
my wife, when she gave birth, I was a little terrified. It was the loudest scream, and I felt like it wasn't necessary.
Well,
she's gonna love
wait,
that.
but did she have an epidural?
No,
Okay, I feel like,
she's a warrior.
yeah, you might need to walk.
But
You felt like it was not necessary?
I just didn't know if could she just breathe heavy, or does the actual scream, and maybe she couldn't control it, but it was, and she'll tell you.
I mean, I would expect she probably couldn't control it.
It was out of body, I think.
Yeah, I think.
I didn't know if maybe there's something maybe the screaming helps.
It's like grunting in tennis.
I'm sure.
Yes, grunting in tennis is a good example.
I mean, I'm pretty sure it's like a good release
Just
of
letting it out.
yeah.
Let the
or
demons
I
out.
also feel like is that what you call your children? No. I just feel like it's like a good, release, I guess, or maybe it's just not out of body experience. I don't know. I have not personally had a child without an epidural, but feeling even an ounce of what you could potentially feel, I could tell you it would probably be an out of body experience. And
Yeah, I could see that. And I think people should scream more. Like I'm trying to think of something that would get me to top of my lungs screaming. It's like there's probably some benefit.
Maybe something coming out of your coins
On
that's
the toilet.
like the size of a watermelon.
Like next time I go to the bathroom, I'm gonna let out a scream and see. No, but I honestly think there might be some benefit. I might look into that.
Yeah, you should. Right, taking notes.
Because they do the
so you
silent
can look
seminars.
into
I feel like there should be one where it's just you're screaming.
Yeah, you're just screaming all the time. No, I just feel like, technically in labor, you get a free pass. So,
Right.
I mean, how anyone acts, what they say, what they scream, the most proper buttoned up women, it is incredibly it's incredible. And then of course they're embarrassed. So they're apologizing oh, I'm so sorry that I was rude to you, or I'm so sorry that I said this or acted this way. And you're listen, you get a free pass unless you kick me in the face that they're you can say or do whatever you want when you're in labor.
Yep.
What's the meanest thing someone's ever said to you? When you were oh, that kind of stung. I felt that one.
No, I don't know. I don't really take any of it personally, so I can't really remember it. Maybe, I don't know.
Nothing derogatory. Yeah,
No. I mean,
swear
definitely people
words
have
and,
said
get outta
rude stuff to
here.
me, but not in labor.
Yeah.
Just more of they don't want to be touched or
don't
checked
touch me,
or
yeah.
anything like that. More of I feel like it's more it's been more, or it is more of a challenge if there's an emergency happening and you're trying to communicate to a patient there is an emergency when they're in a situation, when they're in a lot of pain, or that has been difficult in the past, but not really. Nobody's really said anything mean specific.
Not
specifically
directly
to
at
me.
you or your character.
Yeah,
or
I mean, maybe they have, and I just don't remember. But
Yeah.
What about to their husband? Have they said anything mean to their husbands?
oh yeah,
What can you think of anything that was oh, that was mean?
no, I mean mostly stuff of this is your fault. Don't touch me. Stop
That's
talking.
not helping.
Yeah, stop talking is a good one, because also too, I think some husbands get a little bit nervous and then they want to calm down the energy in the room, so they're just
Relax.
or they're just gonna make some jokes
Yes.
and she's in pain and it's this is probably not the time. I mean,
like-
you guys, I can't imagine you guys have experienced
I was
any of that.
honey, knock, knock. She's ah! No, I can see that though, because when just from the guy's perspective, we don't know what to do.
Yeah.
And there are guys that I know they bring video games, and actually this is actually a good. So I pack a bag
Yeah. For yourself?
for myself.
Okay.
I feel like there has to be a dad bag, and I don't think it's talked about enough. What are things that are inappropriate to put in there? Because I feel like that I've never done the video. I'm not a video game guy, but if maybe if I was, I'd be oh, let me bring my, Xbox.
Yeah.
But I was thinking maybe like a golf club or like a little putting
Little
thing.
putting green. Did you down the hall?
That's what I didn't know. Like I didn't do that. I was
Yeah.
more like make sure I had my dad clothes and like the stuff that you need.
Yeah, I mean that makes sense. That's also a
so that my
response.
wife's comfortable
Yes.
seeing that I'm a dad.
And she doesn't have to pack your stuff for you, like she's your, like you're her child or something. Yeah. No, I mean, I would say there's not really any like big no-nos. Even like the game situation, like maybe you could pack like a handheld thing if you're like a real gamer.
yeah.
I think the main issue is that like when your focus is not really on your partner and they're doing all of this to bring your child into the world
Right.
and you're kind of checked out. I think that's where the main issue is. I think even if you brought a gaming thing, and that's something that we kind of joke about, but people truly do it. I think the main issue is when you go in the room and the dad is just literally checked out, like on his phone the whole time, playing video games the whole time, or is just not asleep and she's like writhing in pain and you're like, I think we should probably wake him up.
It's 4th and 2.
Yeah, like or no, just to,
Right.
or like the patient's kind of like writhing around, has an epidural, maybe it's not functioning well, and he's just kind of like chilling and doesn't look uncomfortable at all. And you're
Right.
like, maybe you should be like, maybe you should sit here and,
At least appear uncomfortable yourself.
or
too.
just like
you're trying.
be like, hey, let me rub your back, or like, hey, you're doing a great job. Thank you so much. Like, do you, or
Yeah.
who knows, maybe, I haven't been in the room the whole time. So maybe she already told him like,
Get
get
outta
away
here.
from me.
Yeah.
Don't touch me or talk to me.
Yep.
And
What about a baby? Has it ever happened where a baby came out and it was obviously not the father's?
Oh, this is good. You've been a party in those situations.
thankfully not. I mean, the thing is, a lot of times when they come out, they kind of all look the same.
Yeah.
So like even from like a race perspective, even babies that are black or brown, darker they come out looking a lot lighter.
Yeah.
So, and then they kind of darken up over the couple days. So usually, no, there's not. I mean, there definitely have been like people joking about stuff like that, but not, when I was in residency, there was a patient, a guy who was in the room, the baby daddy was in the room, and the patient delivered, and he was like super loving, kind, supportive, everything went well. And then later that week, he was there with a different girl
Oh my goodness.
that was in labor.
Wow.
Yeah.
That happens.
Did you
So-
say anything? Were you like, hey, you were
You can't.
nice to see you
It's
again?
It's like a HIPAA violation. Yeah, you can't. No, but he knew. He
Actually,
knew.
that is interesting.
He
to
knew
not-
that he was found out.
Yeah, because if you can't even say good seeing you again. That's like I never even
Right.
thought about. Or like say you had
Like,
a conversation.
how's your baby?
Yeah, you can't even say that,
Right.
which is interesting to think about.
Well, I just saw a big Instagram thing where they were playing pranks on therapists.
Mm-hmm.
So the guy would come in with his like wife. He would say it's his wife, and then they would like argue about things. And then the next day he would come in with his girlfriend, and then
Hilarious.
and then they were basically testing to see how many different girls he could bring in for therapy before the therapist was like, "We're not doing this anymore."
How many did it take?
I only saw 3, but they were like they the way that they cut it made it look like by 3 she was like, "We're done with this. I'm not doing this with you anymore. Like, get out of my office."
Oh, that's hilarious. No, I mean, I would still take care of patients mine would be like the girl would be like there with a bunch of different
What would be the
guys.
max number of children that a guy would have to come with as the father to be like, all right, this
It would
like
almost have
10
to be in like
in a week?
in a week or a month. It'd have to be short. Like
I mean, I wouldn't say anything.
yeah,
You just
You're
keep delivering
professional.
babies.
Yeah. I mean, I wouldn't say anything. I mean, I probably would later like ask the patient when I saw her for her postpartum visit stuff like, how's everything going? Is everything like, and I usually ask about relationships anyway, is like your marriage or a relationship, like everything's okay. You feel safe at home. Like, is he being helpful? Like, are you feeling like you guys are communicating? Okay, that kind of stuff.
Yeah.
So like, I feel like it would come out. Like
Yeah.
she would be like, no, he actually hasn't been home at all. And I checked his Find My Friends, and he's been at like 5 different houses.
This is our first baby, and he knows way too much about childbirth and babies.
He already knows where the bathroom is and like vending machines.
All the nurses are like, oh, hi.
All right, general question, just out of curiosity, percentage of women that come in by themselves. Like out of 100 women, are there anybody that show up and they don't even have a partner, a mom, or
to deliver their baby?
Yeah, to deliver.
Yeah, but usually I would say a low percentage if they come in totally alone. Most of them that are going to be there either have like maybe their mom or their best friend or something like that.
Okay.
If it's not like their partner. And then I mean some of them is more because of childcare situation, like they have little kids at home, and so their partner or whatever is at home with little kids.
Dad's like, this is your fourth.
That.
You'll be fine.
Yeah, he's like,
see you
you'll
in
be
2
fine.
hours.
Or they couldn't, they don't have any family in town. They couldn't get childcare because it's expensive.
Yeah.
But yeah, I mean, it certainly does happen.
Gotcha. What do you think the most pressing, like, women's health thing that we need to know about are the people?
Ooh, that's so good.
You love how we go just jokey,
Yeah.
and
then
bam,
all of a sudden we
serious.
get deep.
Also, this is like this is a hard question.
Is there anything like, well, maybe that you're seeing an uprising in something over the, something that just the Gen Pops doesn't know?
Okay, so the question is just more of like, what does everyone need to know
Yeah, kind of
about OBGYN?
Yeah, just pressing situations that are happening that you're like, man, this is a problem and we're not talking enough about it in the women's health world. Men are dialed. We know that.
I mean, I feel like there's so many. I don't even know where to start. I think really the place to start is really just by listening to women. I think that's been a big thing lately.
Goodness.
It's hard to do, but not that you guys have any experience. I'm sure you guys are great listeners. But yeah, I think just listening to women's experiences and what they say, and like realizing that when there is a collective, there are a lot of women saying the same thing, like, okay, maybe this is something that we need to pay attention to. Yeah.
Okay.
And then, just in general, the research that is out there for women's health, the majority of treatments or things that we use on women are because they were studied on men. And so,
Really?
yeah, women were not included in clinical trials until the 90s.
What?
Yeah.
I didn't know that.
So,
See, that's interesting.
yeah. So a lot of what, is recommended for like general medication, like
Yeah.
high blood pressure medicine,
Oh, yeah.
diabetes medicine, stuff like that is mostly just been studied in men. So a lot of the dosages and stuff are looked at with men's physiology. And so
Right.
kind of looking at women as like a separate entity from men, like we have a different physiology, we can respond differently, we might have different side effects. So I think that's a good thing, important thing to
What
know.
about chlamydia? Is that a pressing health issue
Well,
right
Columbia's we have like some of the highest STDs in the country.
Yeah, I mean, really about 1 in 3 people have an STD.
Really?
Adults have an STD, yeah.
That
So
seems
And there's
pretty
6
high.
or 5 of us in this room. So 3 of us on the mics here.
I mean, I guess we did.
It's looking like. But yeah,
It's definitely not me.
we had somebody early on. What was his name? He was a pharmacist.
Kenrick.
Kenrick. And he blew our minds, like on HIV and some of the STD stuff, and how he was saying like people are having HIV parties so that they could get HIV to get healthcare for their other stuff, which I was like, what?
Yeah, that was men, but that was men. Women weren't involved in that.
I don't know.
Yes.
That's a good question. But no, I mean, certainly, STDs are super common. And so, we treat them all the time and offer screening to everybody that comes in for an annual exam or comes in with symptoms usually. And the recommendation too is if you're 26 or younger that you should be screened annually for STDs, even if you're monogamous. And then, the most common STD is HPV, which causes a lot of different cancers.
Right.
And it just overtook smoking as a number 1 cause for head and neck cancer, actually.
Wow.
So
What do they do for viral infection type stuff?
Yeah, that's a good question. So for HPV, because it's a virus, truly, I mean, it's just trying to support your immune system. And so don't smoke. Hopefully that you don't have any autoimmune diseases, or if you do, like if you have diabetes, that's not well controlled, get it under control. Try to eat well, try to sleep, obviously, because that's the time when the majority of your cellular repair is going to happen.
Yeah.
And then there also is some evidence for like the vaginal microbiome as far as HPV goes for helping to clear HPV infections. But in general, if you have an intact immune system, HPV is going to clear on its own within like 12 to 18 months. There are some more aggressive types that if they stick around for a long time can cause changes or cause issues like that. So really kind of the mainstay of HPV treatment is the follow-up. So if you have a PAP that you have HPV, you're HPV positive or it's abnormal, really the most important thing is that you get your appropriate follow-up and make sure that everything has cleared. Because people who develop, the majority of people who get cervical cancer it's been an issue for a long time. I mean, there are some more super rare aggressive things out there, but they're...
I got another question
Yeah.
kind of out there maybe. And more like, what are you seeing? So with the hormones and things that are in meats and all the stuff that's out there, we've been told there are girls going through, like getting their periods very early. What's the earliest you've seen? And do you find that's because of the xenoestrogens and things that we're putting in foods? And what's going on with the period stuff?
Yeah. I don't really know specifically if it has to do with that. That's something that I really need to look into that and look that up for sure. But girls are getting their periods younger and younger. 9.
9? Mm-hmm. And that should be like
it's considered
13
technically on the end, like the lower end of normal technically now. But certainly could be earlier than that. And then you would need to get evaluated by an have your child evaluated by an endocrinologist. But yeah, they do think some of it is related to environment. Some of it is related to family or your family history kind of stuff. But yeah, that is, I don't do a whole lot of pediatric gynecology. That is technically like a
whole separate thing.
Yeah, but
what age do you recommend somebody starting to go to a gynecologist, like to get checkups or whatever?
So I would say technically your screening for cervical cancer is recommended to start at 21, and your breast exams are recommended to start around 20 as well. But we see women as young as, as soon as they get their period. A lot of times I'll see younger teenagers, just especially because a lot of them are having period issues. So they're having pain when their periods, super heavy periods, pelvic pain in general, those kinds of things. Or they, are sexually active. They need to be tested for STDs. So I usually tell my patients who are moms that, I'm happy to see their daughter at any point. I'm happy to see any age patient and just kind of talk through what to expect, because some like to tell their kids everything. Some are feel very awkward telling their kids anything, or think their kids are going to feel awkward. So then they're like, I just don't want to talk to my kids about this. I'm like, you can bring them. I'm happy to talk to them. And we just usually kind of go over this is what your period is. Ask if it's normal. These are the things to look out for. And then, I give them my safe sex mom talk. Yeah. So
you use a hot dog and a donut?
No, I'm not like, this is how you do it. No. No. Okay. Okay. You're right. I totally miscommunicated that. It wasn't like this is how you do it or anything like that. It's like my safe sex mom talk is probably more conservative, probably because we're in South Carolina. But no, I just tell them about, I usually ask if they're sexually active, and some I think are honest and some are not. Or
Yep,
either
I was
way.
going to say, then they lie to you.
And yeah, and if they lie to me, that's totally fine. And so then I ask them, I usually kick their parent came with them, I kick their parent out of the room. And I'm like, no question is too weird or awkward. You can ask me anything. By law, I cannot say anything to your parent about what you ask me or any concerns you have or any testing or anything like that. The only time that I am obligated to say anything is if you tell me you're going to hurt yourself or you're going to hurt someone else. But we can talk about anything that you want to. And the goal is just for me to be here and for us to have a relationship so that you feel comfortable asking me any questions that you might have, or just for us to establish a relationship. And then I just tell them, deciding that you're going to be sexually active with someone or that you're going to be physically intimate with someone is a big decision. And you're not only trusting that person with your physical health, but you're trusting that person with your emotional health, your spiritual health, all these things. So you really need to consider, what you're doing, because you could be exposing because truly I do feel once you have all the information, if you choose to do that, they're individuals. But I just want them to understand, and not necessarily, because I think a lot of kids just feel like, oh, my mom's just trying to scare me. My dad's just trying to scare me, telling me I'm going to get an STD or I'm going to get pregnant. But I think, having a doctor say it to them maybe helps kind of reinforce it, that like it is a big decision. And truly you are, if you decide to be sexually active with someone, you are trusting that person with your physical health, because, a condom is not going to prevent every type of STD. So you just got to think about it before you do it.
That's good. I think parents appreciate that too a lot.
For sure.
I constantly have parents being like, hey, can you tell them how bad video games are? 12 hours a day on their neck. Yeah, I kind of feel like a bad guy telling them, but I'm like, it is really bad for you to just play video games all day.
I'm sure it is in a lot of different ways.
Yeah, mentally. I just think about it physically, like to have your neck in that position. Like you should be out playing and doing something else, not staring at a light all day long.
That's true. Yeah.
So you mentioned like breast exams too. I'm curious if the big shift toward breast implants, what you're seeing there, is there an age that you're like, oh, these people are doing this way too young? Is there certain types that you're finding are coming in with more issues than others?
No.
Because I feel like you always hear like the kind of the plastic surgeon side, or then you hear like the patient story side, but I've never really heard it from a OBGYN perspective.
Yeah, no, there certainly are like women of all ages that have breast implants, but all the ones I've seen are adults. So they're over the age of 18 if I've seen them, and they have breast implants usually. And I haven't really seen anything kind of like odd, but I feel like seen a shift more towards patients who were considering breast implants or who have breast implants getting them removed, just because of like, they get a scar tissue, like a contracture formation around it, or they rupture, or, I think you have to, depending on the type that you have to get them replaced at a certain interval. I think it's like 10 years or something. Don't quote me. I'm not a plastic surgeon. But yeah, no, not necessarily, not seeing anything odd there, just more like more seeing younger women that are being diagnosed with breast cancer. So now there's a big push to know what your breast cancer risk is, that your doctor, your gynecologist, or your primary care doctor, if you don't have a gynecologist, but your doctor should be assessing your breast cancer risk by age 25. And if your doctor hasn't done that, you can do that yourself. There's a risk assessment score called the Tyrer-Cuzick. It's TYRERCUZICK risk assessment. It's free online, so you can just Google it. And it asks you a whole lot of questions about your history, about your health, about your family history, and it estimates your breast cancer risk at the end of the assessment. And it tells you if you are high risk, when you might need to start screening, that you need to send this to your doctor. So I'm seeing a lot more of that, or maybe just seeing patients who have never really had their breast cancer risk assessed and then realizing that they're high risk. And so that they needed to be having breast cancer screening earlier. And then the other thing too that has changed a little bit is that the FDA is now requiring that radiologists report breast density on mammograms. And so if your breasts are considered dense, then you have an increased risk of breast cancer. So a lot of times that, along with your risk calculation or your age, you might also need a breast MRI to screen for breast cancer.
Do you think it'll ever move to just breast MRIs all the time?
Or thermography.
Or thermography.
I mean, I would say maybe breast MRI if it becomes a lot cheaper and more accessible because it is more sensitive. But mammography is still the standard because breast MRI is more sensitive, but it also, by that, you're going to get more false positives. So there are going to be more things that you see that end up getting biopsy that end up being nothing. So that is a risk that you're taking with that. Thermography, the idea behind that is that there are areas that are abnormal that are causing, releasing like heat, because they're essentially physiologically active. But at that point, it's kind of too late. So the idea of mammography is to detect something before a physical exam would detect it, so that with early detection, you are able to treat it quickly so that you don't have a poorer outcome, basically. And so, and some patients do also have the concern, especially now, of the radiation that is they're getting with mammography. And I try to explain it. It's about equivalent of like a transcontinental flight, the amount of radiation that you're getting with mammography. So I usually encourage patients to get it, but I also understand, if everybody has their own kind of what they value, what they want, what kind of risks are acceptable to them and what are not. And I just kind of try to support them.
Because you have to squish it quite a bit too while you're doing it.
I think so. I mean, I don't do the mammograms,
I've
but
never
I
had
hear
one either.
Oh,
That's
I
what I
do
hear.
them. I do them often with my wife, but
that's not a mammogram. I'm a doctor and I can tell you it's not a mammogram.
I just tell her it is. All right. So tell us about all the different types of births, just so everybody kind of knows. So you have natural vaginal, which means like they do nothing, like just literally out in nature, essentially.
Like
right?
Outdoors.
Well, like literally no intervention at all. Then you have vaginal epidural, let's say.
Okay.
Or and you tell me, like, I don't know. That's why I'm asking. Then is there like
No, I'm just going to let this keep going because I'm really...
Vaginal epidural Pitocin, let's say.
Mm-hmm.
Then there's C-section.
Mm-hmm.
Is that
Yeah.
all of them? What else am I
There'd be
missing?
like an assisted with like forceps or
Forceps, vacuum. Do they still do those? Mm-hmm. Really?
Yeah.
That sounds intense.
It is intense. Yeah. So I would say, I would usually, or I would say, I guess OBGYNs would classify births as like vaginal, spontaneous vaginal assisted, and then cesarean section. So spontaneous vaginal just means you
Driving down the highway.
like the
Baby decided.
like the baby comes out,
Oh.
and you're kind of there. And then the assisted vaginal is going to be like forceps or vacuum. And then a C-section obviously is a C-section. So we consider kind of natural is not really like the...
you guys don't even want to toss it in the categories.
Yes, because technically then that's saying like, a C-section birth is unnatural. So then that...
Doesn't it feel...
which is true, I think.
Yeah, doesn't it feel like you cut a hole?
I think, but the issue is, the issue is that I think people that are not able to have a vaginal delivery
don't want to be categorized as like
unnatural
I can see that.
or whatever. But yes, so essentially you can do you can have a spontaneous vaginal delivery, and if you are having a vaginal delivery, you can go into labor spontaneously.
Gotcha.
So let's say you're waiting on labor, you go into labor on your own, you decide that you don't want any interventions, and you don't have any interventions, your water breaks on its own, and the baby delivers, and that's it. Then you can have a vaginal delivery where you might need an induction for a medical reason, or you might elect to have an induction for different reasons. And so then you come into the hospital. Sometimes you'll come in the night before, sometimes you'll come in the morning of, get induced, have your baby. And then I'm trying to think of, and so there are a lot of different measures for pain control. So you can have a baby with an epidural, without an epidural. You can have like a water birth, or what you guys had, right?
Yeah.
So you can have a water birth or deliver on land.
Land or sea.
Yeah.
Both of our kids came out into a tub.
Oh, cool.
And it seemed
Where-
like it
where
was
was
cool.
At the
Tub.
YMCA.
Where was the tub? That's
The
what I was wondering.
the tub was in our living room.
Like, was it a hot tub? I'm just kidding.
It was
No, that's cool.
So I
Wait, here?
This was in Canada.
Okay.
But yeah, I don't. So the first one I screwed up and I like used all the hot water up before, and then like wrecked
taking
the
a hot
tub. So I was
shower.
trying to like
Then
boil.
your baby
I was
had to
trying
be
boil water.
resuscitated.
No, I was trying to boil water and like put it in there, and it was just so cold for her. So I felt bad about that one.
Neighbors were bringing over
But she
water.
did great.
weren't they?
Yeah, I was like calling my neighbors, like, you got to boil some big pots of water and bring them in here to put in this freezing cold tub.
Like literally this much water pouring into a bathtub is Allison. That's great.
Yep.
All right,
pulled that
so
one off.
I guess then of the births, percentage wise, like, are there a lot that you get to see? Like, do you get to see a good variety, or do you find it leaning more? Because we hear like C-sections in the U.S. are the highest,
Yeah.
and I wonder why about that too. If you have like an opinion on why here versus
Other places. Yeah. I mean, I would say that in general in the United States, C-section, I think the C-section rate's about 33%. So, I mean, that is an important thing as a patient going into a practice to know. I mean, you personally, I would want to ask the practice, like, what's your C-section rate?
Right.
Or maybe the doctor that you pick, if your doctor is going to deliver you, like, what's your personal C-section
like
rate?
that.
So that is good to know if they're like on par with average, or ideally you'd want below average. Also, I didn't mention the other type of birth, which is a VBAC. Can't believe I missed that. Vaginal delivery
Boom.
after C-section. Yeah. But anyway, sidetrack.
on the list?
I don't even remember what I was saying now.
You're saying percentages of things to ask your doctor.
Yeah. So like a C-section is a relatively high percentage in the United States. And I would say as an OBGYN, I don't see as many spontaneous labors that are not augmented. So like they go into labor on their own. They don't need any kind of intervention. Patient delivers on their own, because a lot of times we do have like a midwifery group that we work with. So
Yes.
a lot of times they are taking care of the low risk patients that usually don't need any kind of intervention. And really, a lot of the reason that you might need an OBGYN is because you might need an intervention, or because your
Right.
pregnancy might be more high risk, or things like that. So
That might answer it then. Is like we have a lot of high risk people just because of our health in the
Yes.
U.S.
Yes,
It's so
and that's
bad.
and that's what I would say. I mean, in general, and that's what I would say honestly for the C-section rate too. But a lot of it too is going to be individual to the practice, because what you guys know, I don't know, chiropractics might be similar, but it's just medicine. Like, we don't have all the answers, and we just try to do the best that we can with the information that we have. And people trained in different places and train differently. Some people are way more motivated to stay on top of like their learning and make sure that they're providing top-notch care and everything that's evidence-based and up to date, and they want to change with the times. Some people don't want to change with the
Right.
times. They just want to kind of do what they were taught, and it's been working this way, so they're just going to keep on doing it. And it just, it's sometimes I think hard as a patient to figure out where people stand.
Yeah,
so,
definitely.
Yeah.
Ideally, you want the person who's up on their stuff and is not going to intervene, until they need to.
Yeah.
And I think it's hard sometimes for patients to assess.
And I guess with that, advice that you would give women that want to get pregnant and have low risk pregnancies would be like I'm guessing body weight, blood sugar, like low blood sugar or normal blood sugar.
Yeah.
What are some of the things that are like just are high risk that you're like, this is going to be an automatic high risk? No, like if they get pregnant, they are.
Yeah, it's going to be
It's
a
a tough
difficult
situation. Yeah, it's
pregnancy.
just tough
Yeah.
to get pregnant, I'm sure, and then tough pregnancy in general.
Yeah, I mean, no, I think I would just say like focus on optimizing your health before you get pregnant as much as you can. So yeah, like trying to be overall at a normal weight, but also, you know, it's not necessarily that you just need to focus on, you know, doing X, Y, and Z to meet these goals, but like you really want to focus on changing your habits and changing your lifestyle. Because ideally, you know, pregnancy is a great motivator for us because we all want to be good moms. We all want to be good parents. We want to take care of our kids the best that we can and ourselves the best that we can. And so I think it's a good motivator for a lot of people. But yeah, like if you have high blood pressure, if you have diabetes, if you have kidney disease, things like that, you want to try to get under control. If you're on medication, you want to see a doctor early on and just see if the medication that you're on is going to be safe for pregnancy, and then getting any like preconception labs. If you have genetic conditions that run in your family, or you want to get evaluated to see if you might be a carrier for certain genetic conditions, you can get that done. Then, you know, seeing if you are immune to rubella or essentially German measles or varicella, like the chicken pox, because those can cause birth defects if you get infected with them when you're pregnant.
Yeah.
And then, you know, sometimes I'll screen people's like thyroid, check their vitamin D, stuff like that. Just make sure their nutrition's optimal, especially like gastric bypass patients.
Yeah.
You know, they're more at risk for nutritional deficiencies. So, looking at patients like that. But yeah, just using preconception to think about habits that you want to carry forward and in your life with your kids, and just trying to optimize your health. And then just finding the practice. I would say find the hospital where you want to deliver and see what doctors or midwives or whatever, figure out where you want to deliver and see who delivers there. And then kind of work backwards that way. And then asking, like, I think the biggest thing or the best advice that I can give patients is to just figure out what's important to you, to figure out what matters to you and who you are and what you value, so that you can hold true to that when you have, you know, where you might not be in a situation where you and your doctor are congruent, where your doctor's, you know, saying we need to do this. And you're like, but I really value low intervention.
Right.
And so then you can say that for yourself, like, hey, I really value low intervention. Is there something else that we can do? Is it really, how dangerous is it if we don't do this, if we just keep watching and waiting, you know, those kinds of things. So I think really just knowing yourself and what you value, what's important to you, and knowing when to, you know, flex
I think
on those.
A lot of times people are just choosing their OB based off of insurance, which is like the worst way to do it. It's like,
I mean,
I'm with you on like, I want to know, what was your percentage of C-section? What's your
honestly
philosophy?
I mean, honestly, OB care in the United States is just dismal. Reimbursement for women's health is terrible. And so I think that is why OB care is so bad. I mean, patients that I see literally throughout prenatal care, you have a 10-minute visit with your doctor, you know, they're scheduled they're scheduled for a 15-minute slot. That includes the time from when you check in to the time you check out. That's 15 minutes for, let's say it's your 20-week visit. So at the 20-week visit, we usually do the anatomy scan where we're doing the ultrasound to screen for congenital anomalies. And so we're looking at all the parts of the baby. So that also includes all the time that it takes me to look through all the pictures of the ultrasound, to read the ultrasound, to see the patient, talk about any concerns that they might have for the pregnancy. So it really, you don't get to do a lot of anticipatory guidance for patients or a lot of education. And that is what, you know, and it's no excuse. I mean, we really shouldn't be walking in the room being like, hey, you got any questions? Okay, everything looks good. See you next time.
Right.
But that is what a lot of OB care ends up being. And it's a disservice to women. And there's no wonder why our maternal morbidity and mortality and neonatal morbidity and mortality in the United States is so terrible.
I did see on Instagram you had something where you were like warming up to jam 90 minutes worth of stuff into a 10-minute appointment.
Oh yeah, but I don't do that. I take 90 minutes and then I'm running like 2 hours behind. So it's fine.
Yep.
It's fine.
Yeah.
I feel like you can easily get worn out as a medical provider. Certain questions or things or issues, and pretty soon you're just like, I'm just exhausted listening to this.
Yeah, I mean, no, I really don't I feel like it's more like the healthcare system that wears me out, not necessarily the patients.
100%.
I love the relationships that I get with my patients, and I love listening to them and trying to figure out what's going on with them and figuring out kind of like a plan with them and how to fix it. And that's the cool thing. I mean, maybe this is all of medicine. That's the cool thing. But I could see, on paper, the exact same person back to back, like a 50-year-old patient who is like perimenopausal or menopausal and complaining about hot flashes, X, Y, and Z, has the exact same complaints, exact same comorbidities, and they walk out the door with 2 totally different treatment plans. And it really just comes down to what they value and their risks and benefits and what they decide that they want for their care, which I just think is so cool. And so that's what I like. I like listening. But I think the part where it does wear on you is that you have all these close visits packed in back to back. I mean, you're seeing 20 to 25 patients a day, and it's that everybody deserves the time for you to listen to their story and figure out what's wrong. And, 15-minute visit might be fine for somebody that has no complaints or issues. All they need is their breast exam and their pap and you to refill their birth control, and they're totally cool. They have no complaints or whatever. They say no to every question, and they're like, all right, see you later. But 15 minutes is not okay for someone who has been dismissed for the last 9 years about their pelvic pain, and they feel awful about their marriage because they haven't been able to have sex with their husband because they're in so much pain, and everybody has been telling them that this is normal. Plus on top of that, they have super heavy periods. They're anemic. Plus, on top of all these things. You can't, in a complex patient, you cannot take care of the whole person in 15 minutes because you just don't even have time to really even get a good history in that amount of time.
Yeah, medical scheduling is just the worst. Chiropractors crush you guys on wait times.
Oh, I know. You crush us on a lot of things. Probably patient satisfaction.
Yep.
Probably. I mean,
Keep going.
Salary.
But it is, one of the things that I think about is you show up for an appointment on time or 15 minutes early, and you're going to wait in the waiting room for 45 minutes usually. And then you're going to go to another room and wait another 45 minutes from now. It's like, you can't plan anything. It's
naked, basically, in a paper. Thankfully we have real robes at my office, but in a paper gown, and then you're sweaty because you're nervous, and then it starts dripping, and nobody tells you where an extra gown is. And
then I'm in a paper gown, and I'm not supposed to be because I'm opening all the cabinets.
There's funny, when you watch movies and they have an OBGYN or someone's giving birth, you just laugh at it. I was thinking about the one, I can't remember what it was, but the OBGYN, he kept making small talk when he was with the woman, and she was like, I don't want to talk to you about this right now. And he's like, so how's your husband? And he's got the
speculum.
Speculum, yeah.
Mm-hmm.
Is there, I guess, what do you do when you're in the, what do you call it?
Down there?
When I'm doing a pelvic exam?
Yeah. Do you call that anything? I feel like it should have a name. I'm in the zone, or I'm in the
trenches.
Trenches.
When I'm doing a pelvic exam?
Yeah. I guess where they can't see you, right?
Yeah.
So it's kind of all right, I'm heading going down. I don't know. It'd be nice to have a name. All right, see you in a little bit. An elevator.
I'm usually just like, okay.
Do you ever do the elevator though, where you're like, all right, boop, and then you slowly dip lower?
No, but I'm going to start doing that. Only on select patients, though. You can't really do that if someone's nervous. They won't think that's funny. No, I mean, I usually just say what it is and try to explain it to them. Okay. Especially if it's somebody, it's like their first PAP or their first pelvic exam, because there's a lot of confusion around like, what is a pelvic exam and what is a PAP and what is a speculum exam and what is a bimanual exam. There's all these like different kind of things that you can have done down there and different reasons. So I usually just explain kind of what those are and what I need to do or what, I would recommend. Like you're due for your PAP or you're not due for a PAP this year. So usually if you're not having any complaints, I just do a quick internal exam, feel the size of your uterus and feel for your ovaries, make sure everything feels normal. And then, that's basically it.
Do you feel the need to like peek around to talk to them, or you just talk while you're down there? I didn't know.
I just talk while I'm down there.
Okay. All right.
I mean, unless I feel like sometimes if I'm doing a procedure, like let's say like I'm placing an IUD or I'm removing a cyst or I have to inject some like numbing medicine. Yep. If I'm concerned about their pain, and some patients are a little bit more like close to the vest, like they're like, yeah, I'm fine, but you can kind of tell by their demeanor, then I'm like kind of peeking. I'm like looking at their face, but I also do have a medical assistant, or I usually try to have a chaperone in the room with me. So a lot of times I can tell by they're usually kind of like where you are, and then the patient is here. Gotcha. So I can tell a lot of times by their face if there's something weird going on that I need to like, if they're like, ooh, or they'll tell the patient like, take a deep breath. And then I know that things are, so then I like stop. And I also tell everybody before I do a pelvic exam, if this is painful, especially if it's the first one, like it should not be painful. It might be a little bit uncomfortable. If we need to stop, let me know and I will, or whatever.
Can I throw a wild concept out that I think the world might think is wild, but I'm curious about where you're at on it, is pediatric chiropractors checking babies right after birth. Where are you at with that?
Oh, interesting.
Because that's our norm. Like our kids, but I know that the world might look at it and be like, wait, did they say they have a headache or a neck pain?
No, I mean, I feel like people I think, well, you can correct me if I'm wrong, because I will admit that I don't know like a ton about chiropractic, but I do know a little bit. But I feel like sometimes like traditional physicians' perspective of chiropractic care is that like it's something more invasive than it is, or something more like dangerous, manipulative, or like, and I know a lot of times chiropractors who do work on babies, it's a much more gentle touch. It's not like a manipulation. Correct. It's just more about like the tension and like kind of helping resolve the tension for the baby. And I do know that a lot of like feeding issues and stuff, or a lot of like tension can contribute to feeding issues and things like that. So I would say, I think a lot of lactation consultants would agree on that. As far as that goes. I mean, I usually just tell my patients, like, use your judgment. Same thing in pregnancy. Like, use your judgment. Go to somebody who does this. Yes. Don't go to somebody that is like, oh yeah, I'm a chiropractor. Opens their garage door. Yes. Or like, or
I've
like,
never done it before, but it seems easy.
Lay down.
But let's start with the neck. No, I mean, I think like, for instance, like obviously you guys have been around for a long time. You guys have several different locations. Yes. Have good reviews on your website. It says what you do. And it says that, I think if it says like, oh, this is what this is my special interest, that kind of thing. Those are obviously people who do it a lot and they enjoy doing it. So they're going to be kind of up to date on everything. And I usually just say, use your best judgment. And as long as they're certified, like I usually tell pregnant patients if they're Webster certified, I mean, that's what I would go with. And as long as you feel comfortable, then
nice.
I think it's fine. Yeah.
It's great.
I mean, I think it can be like, I think chiropractic can be a great adjunct to.
Our thing was always like, it's the most traumatic thing that the baby's going through, when whether it's vaginal, unassisted, whatever, but the pounds of pressure that it takes to come out and to think like, oh yeah, we're lucky the baby's vertebrae, are all in place. I always looked at it like that should be the standard, like just like anything. Come check the heart rate, check the lungs, now we check the spine just to make sure. And you're right. I think the perception is people think it's like we're gonna come in and like crack a bat, or like it's it's like checking the ripeness of a tomato. That's what it's like for the baby. And then when you
that's a
see
good way to explain it.
yeah, when you see this baby's like melt into like ease, it's like
and then they like fill their diaper up.
Yes.
And you're like, oh,
yes,
That does happen a
it's
lot.
So that's why I'm glad you're here, like, because it's just interesting. Like, there's so many gaps in what people just don't know, and we want to make sure there's a platform people can hear about that.
I think there's also a lot of like misperception between the different, I don't know what you call them, like different realms of like
Chiropractic, like
clinicians, like I guess, or practitioners or whatever. So you said the OBG, like, what did you ask me before about who OBGYNs beef with? Chiropractors, maybe I should have said.
Chiropractic, probably.
Like, complementary medicine providers.
Yeah.
No, I mean, I think there is a huge misunderstanding, and that's why I really wanted to do this. I did like an integrative medicine, or I'm finishing it now, but an integrative medicine certification, just because a lot of my patients ask a lot about things like that, and I just
get more knowledge on what's out there,
and also just do them, a better service by knowing what can be helpful.
Yeah, and people want that too.
Yeah.
Like, we get asked all the time, is there anybody who just has some knowledge of like the natural space, or at least will like kind of meet me where I'm at and help guide me? And I pretty much just always said, I have no clue. No, I don't. I literally don't know anybody.
Well, now
I
you
don't
know
know if
someone.
they're out there. So I thank you.
Yeah, now you know someone. And like I didn't realize until I was looking at you guys' website that you did babies and pregnant ladies. Mm-hmm. I also don't think I realized like how many chiropractors are in you guys' practice. So I'm going to be sending people to you. I need to get some business cards.
Awesome. Oh yeah. Couple more quick questions. Yeah. Birth control. I feel like we got to hit on that. Mm-hmm. Another thing that I feel like we're just giving girls so early that somebody once told me, I thought it was supposed to be like a short-term medication, and maybe it's changed clearly because people are on it for like 2-3 decades sometime.
Yeah.
What are you seeing and I don't know if it's like age of start or length of time, or what are you seeing any challenges with people that have been on it for so long and or coming off of it, and what they go through when they do, and then alternatives to, instead of something chemical, what could they do to still have birth control without taking something?
Yeah. I have I feel like that's a lot of questions. I'm gonna have to remember.
Yep, I have a hammer in there.
Just a couple more quick questions. Actually, there's like 10 in this one. No. Oh gosh, I feel like I have so much to say about this. So I think there are a few different issues in the birth control realm. I think one of the biggest issues, I'll just say in mainstream medicine, and what we call evidence-based medicine, and might get some hate for this, but hopefully not a lot of people. I love where you're going,
I think, already
answer.
with the air quotes.
Not a lot of people listen to this.
This is Columbia's hottest.
But I mean, I think that as far as evidence goes, of course, there are different levels of evidence that we look at and talk about when we are looking at medicine. But there also are individuals, and there are people that kind of go outside of what studies say and what evidence says. So, of course, in general, these studies on birth control say that it is safe, that the side effects are either not there or they're very low, and it doesn't affect X, Y, and Z. It doesn't cause all of this, or, and then you have a patient that comes in and says, like, I started this birth control or medication, whatever. I started this birth control and all this stuff started happening. And so then I stopped it for a few months and all these side effects went away. And a lot of times I think these patients are being met with traditionally trained physicians saying, well, that wasn't from the birth control because there's not evidence to support that. And just because there's not evidence to support it doesn't mean that it's not true. Everyone is an individual. And so that's what I usually try to tell people is like, that might not be a side effect that is regularly reported in the literature, but it doesn't mean that's not a side effect for you.
For that person.
And I just think that we really need to be more careful as far as, I think evidence-based is great and evidence is great. And I feel like my practice, I try to think of as more of like evidence-informed practice. Like, of course, evidence is good, but the patient sitting in front of you is going to be the best barometer of what's going on. And so I think a lot of our evidence-based medicine, that we can wield it in a way to dismiss a lot of patients and a lot of patients' symptoms because it's not something that's been shown in them. So I'll say that first.
Yes.
And then the second thing about birth control that I think is a huge disservice to patients is that girls are put on birth control for a lot of different reasons. Obviously, one reason is contraception. Okay.
Right.
That's fine. But I think a lot of the other reasons are that you go to your primary care, your pediatrician, or you go to an OBGYN and you are young, you're let's say 16, 17, you may not be sexually active or you might be, and you say, I have heavy periods, or you say I have painful periods, or you say my periods are irregular.
Yeah.
And they say, okay, well, here's some birth control. It's going to make your periods go away. It's going to make your periods a lot lighter. And there's no investigation
Of
done.
why,
Or no explanation to the patient. And so sometimes even if the clinician, so like, even if I think like, okay, what you have, your heavy periods and period cramps that are painful to you are more like subjective. I don't think this is really like, you don't have necessarily anything pathological going on that needs to be fixed, but explaining that to a patient goes a long way to say like, this is what birth control is. Like a lot of times people just don't get that explanation. So then we're seeing patients 10, 15 years down the line and they've stopped their birth control because they want to get pregnant. And now all of a sudden they're not able to get pregnant because they've been on birth control for this long and they've had something underlying going on that was never investigated or just was never taken care of. And so I think that is the main issue. And I think that's also a problem with the healthcare system, right? You're in a 15-minute visit. Somebody comes in and says, oh, I have heavy periods. You're like, here's some birth control. All right, see you later. Come back in, a year. We'll see how you're doing. So, I mean, I would say those are the two main things that I would say about it is that I think birth control medication, specifically like the pill, so like combined birth control, which is like estrogen and progesterone, I think it can be useful in a lot of different ways, but I think it's important, especially if you are taking any medication, but if you're taking it, to understand why you're taking it and what it's doing and what's in it. And so I mean, certainly there are risks to taking every medication, and those risks are general, but they also are individualized. So, definitely some things that I think that people don't think about maybe, or maybe experiencing that don't realize that it's a side effect of birth control. So basically what birth control is doing is it's kind of just giving you a steady dose of a synthetic ethinyl estradiol, which is the same estrogen that's in every birth control, which is a synthetic estrogen, and then some type of progestin, so a synthetic form of progesterone. There are different progestins in each birth control, and there can be different doses. There's like a million different birth controls. So, I mean, even as an OBGYN, I have a few that are like my go-tos, but like there is an entire article that has like so many different birth controls and specific doses. And also like this one birth control can have like 5 different names. So it's very confusing. So, what the birth control is doing when you're taking it is just giving you a steady dose every single day. It's preventing ovulation, but also when you're getting this steady dose, depending on what your body is used to, you might be kind of at a lower level of estrogen than what you're used to. So then you can have low estrogen side effects, which are going to be like vaginal dryness, pain with sex, low libido, vulvar pain in general, which I've definitely seen with people on birth control. And now I'm not going to say like, don't take birth control because that's going to happen to you. I'm just saying you just have to know.
Be aware of it.
Yes. And you have to know why you're taking something.
You know what? Like I always struggled with just like my chiropractic brain, if you will, is I love when the body does something, it's doing it intelligently, right? Just in general is like my baseline. So pain, it's intelligent. There's something wrong. It's telling you. Periods, so that is meant for the woman to slough off and bleed. And if we stop that, we're going against something that the body wants to do. And what I struggled with was year after year of that, what is happening to the stuff that is supposed to be naturally kind of coming out?
Yeah, no. Oh, that's a great question. That I think is kind of a little bit of a misconception that a lot of people have, that the period is basically a buildup of these toxins or a buildup of this blood or whatever that needs to come out, or tissue. So basically what's happening when you are on birth control pills or birth control in general, so let's say you're on the ring, the patch, the IUD or whatever, actually it is thinning the lining of the uterus because you are not getting this. So normally when you're not on birth control, and everything is working how it should be, you're getting kind of these spikes and troughs of estrogen and progesterone. And so that whole cycle is influencing the thickness of the lining of your uterus. When you're on birth control, you are just kind of getting this steady dose, the same every single day when you take it, and it is thinning the lining of the uterus. So truly, if you look at the lining of the uterus of someone who's on birth control, it's pretty thin. And so over time, that can, if you take birth control consistently for a long period of time, sometimes it can thin out the lining a lot and you just don't get a period at all, or you might start having even irregular spotting or irregular bleeding because the lining of the uterus is so thin. I would say right now we don't have any evidence that birth control necessarily contributes to infertility, and as far as, what's happening when you're on it for all those times, like the eggs that you have in your ovaries. So basically you are losing a group of eggs every cycle, and that continues to happen even when you're on birth control. So it doesn't prevent that from happening. Okay. And then also taking birth control for more than 5 years has been shown to decrease the risk of ovarian cancer and colorectal cancer. So there are, some good side effects to it, but certainly, and there are cases where the IUD thins out the lining of the uterus a lot. So that could cause issues with implantation if your body is not able to kind of reset itself. But right now, there's not any evidence that shows that birth control contributes to infertility. Sure. But I get what you're saying. And I think that is the way a lot of, I think women are now kind of looking at things of I kind of want my body to do its own thing. Yeah. And I think that's great, especially if your body is doing its own thing. And this goes back to a question that you asked that I didn't answer, but, tracking your cycles and trying to prevent pregnancy or avoid pregnancy that way. You certainly can do that, but you need to be able to do it well.
Gotta know your stuff, yeah.
And so I think that's the hard part for a lot of women too, is that you really have to be in tune with your body, which a lot of us as women we're just not. Yeah. So, because we just have either been written off or dismissed, or we dismiss our own symptoms. And so that it takes a minute to kind of figure out what's going on with your body. Right. But I think that's great if people want to do that and track, but you do have to do a good job and stay on top of it. But it can be very good at preventing pregnancy, 98%. So.
And sperm lasts a long time. That's the problem.
Yeah.
Especially Randy's.
Especially mine. They say average is 3 to 5 days, but I think I'm closer to 10.
They learned how to checked. Do you know
how long it lives? I guess what would I do? Put it under a microscope?
No, I'm saying if you've had a semen analysis, you don't know. You don't really know if it's normal. Point. It might be. You might have some sideways swimmers.
That's true.
You might want to do a petri dish.
But I don't know.
Right, do a petri dish.
What? And so, what about the pull and pray method? Do you hear a lot of people doing that?
Yeah, there are some people.
You got a pamphlet on that?
Yeah. I don't. Is that how you got?
What are my options?
Is that how you got
condom,
your kids?
Pull and pray. So here's the thing. I always thought that it wouldn't work that well.
Yeah.
So
But
like,
his
I have a,
spiritual life is
well, no, I have a friend because I have a friend who says that like all 3 of his kids were from. He says they're from pre-cum.
Yeah,
Meaning, like,
yeah,
well, there's no
yeah.
way, he says. But I think he's just lying because I know multiple people who that's their method, and it's like, all right, we're ready to have a baby, boom. All right, ready to have a baby, boom. And it's been fine. And I've always just thought like, I don't know, I don't want to try to have another one, but like if it happens, it happens. I'm willing to.
How
like,
old are
roll the-
yours now?
They're 11 and 8.
Okay. I mean,
it's been working.
But both were just like both times it was like, all right, are you ready to have one? Yep. And then I was like, all right, I know, like you're ovulating this day. So day 11, 12, 13, 14, let's go.
I mean, I think it definitely can work for some people. I mean, I don't think it's like it's not as as effective as like tracking your cycles and all that stuff.
Right. You just have to have some people don't have that good of self-control either that they can handle it.
Well,
Some people, you.
No, I listen, I'm 2 for 2 when I tried.
So, well, you know what's interesting is a lot of people don't know that you can only get pregnant during ovulation. Like that's another thing that I think people were surprised.
And I think that's the hard part too, talking to people when they're ready to get pregnant, is that I see a lot of patients that have like, they've been trying to get pregnant for a few months and they're like, we're not pregnant. Something's wrong. I'm like, no, you really only have about a 20% chance of getting pregnant each cycle if everything's working perfectly. Right. And I think we all are scared going back to our parents about like, everyone scares you that you're going to get pregnant the first time if you have unprotected sex, or if you like look at a penis, you're going to get pregnant probably.
Toilet seat.
Yeah.
I thought for years
that you were going to get pregnant from a toilet seat.
You're just like praying at night, like, God, please. And that and like AIDS and HIV, I was so scared of because like,
oh my gosh.
So I was like, maybe I have it. So I'm just going to
checked out so many books about AIDS in the library. My mom probably thought
that was our era. It was like, God.
Yeah. Anyway, what were we talking about?
Randy's
I know.
guys live in it a long time.
So sperm can live for 5 days in the reproductive tract, and the egg is only good for 24 hours. So really, if you want to get pregnant, you want sperm to be there waiting when the egg gets released. So that's kind of your best chance.
Well, and I think if you want to get pregnant, you should do some research too. Like if it's day 25, your wife's going to start her period tomorrow. Like, there's
maybe
no
if
point
your
in going to it to
are
A.
26 days.
She's gonna, or what if you know how long it is. But like if you know, like, all right, it's probably starting tomorrow. Like, she's not going to get pregnant, and she's not going to want to. So just like,
so just leave her alone.
Wait for 15 days.
Just
and
go
then
play your
get
video
after it.
games.
Pack your death bag.
Don't touch her.
Okay.
Yeah, try in the follicular phase.
Yes, it's easy.
Yeah,
but
it's
see,
easy.
people don't know. Like that's the thing. The average Joe. I mean, if you walk down the street and just ask people, they'd have no clue. I would say probably like 80-90% of people.
Yeah, I agree. So the follicular phase is going to be basically after the period stops until ovulation.
Yahtzee, go time. They can't say no during that either. Is that what you're saying?
No, we're not allowed to say no during that time
trying
either.
to put me in a bad situation?
Trying to clip you. All right.
No, you can say no anytime you want to for any reason. Consent should be enthusiastic.
Randy and I's fertility classes, though, if you sign up for that, there's a section on it. Okay. Infant mortality. I had this written down. Very poor in our country. Does that go back to like the same thing? Like like just the health of our country is just so bad?
Well, I also think because babies are delivered a lot earlier too, so that is going to contribute to a lot of that
like
too.
in the U.S.?
Yeah, because a lot of times, if you're having a complication in pregnancy, depending on what's going on, you may need to have an early indicated delivery. Or also like multiples are more likely to come earlier.
Gotcha. Okay.
I was going to joke and say it's probably from all the chiropractic adjustments.
I was going to say they need more chiropractic adjustments.
I have one more question, but it's off the wall.
Oh boy.
As expected.
It might be okay, go ahead.
It might be the same question as you have. Do you have many people where their husband is too big and it's like damaging their cervix?
I don't have that written down. But I'm sure my wife has concerns. Is that why you're bringing it up?
Someone called in and asked.
We have a call in here. Is this Megan Stetson?
Yeah, I was like, is that... No.
Oh, okay.
No issues.
No
Okay.
issues.
No damage. Okay.
I don't know if I should elaborate on that one.
You've been under the hood and you haven't.
No.
That wasn't one you picked out and
no,
said.
that's not. No, actually, so the vagina can get like pretty wide and also pretty long to accommodate
Length
almost
and
any girth. Yeah. Unless you're like postmenopausal or you're breastfeeding, you have low levels of estrogen, and then the tissue is going to be a little bit more friable at that point. So probably anything is going to be uncomfortable.
Yeah, girth seems like it would never be an issue. It would be length, I would think.
I mean, I guess.
Yeah.
Yeah.
It's got to bottom out at some point.
It doesn't go forever.
I mean, it's just anatomy.
I should have known this was going to go this way.
All right. Now
You'll
for
be-
birthing, Randy's a proponent of roughening up the perineum. Have you seen
No,
that?
I'm
No.
massaging the perineum
perineum.
and
roughing the
roughing up
nipples.
the
Sorry,
nipples.
roughening the nipples and
Roughing.
stretching the perineum or massaging it
Yeah.
that's beneficial, correct?
Yes. So
Okay.
there is some evidence that that perineal massage starting around like 36 weeks or so can help decrease the risk of like a severe perineal tear. And warm compresses like at the time of pushing and delivery.
Okay.
And then the nipple stimulation, I don't know that I would have to look into that.
He more so does
'cause
that
I
to
have-
prep.
to himself.
I made that up.
Yeah, he's not doing it to her. He's like, we gotta get ready, honey. What are you doing? Oh man. I guess it.
No,
right.
but so that releases like oxytocin, and
gosh.
it's supposed to help with like labor, not need augmentation or potentially help start labor. But I don't think, as far as like starting labor from like a 0.0, like you're not in labor at all, I don't think necessarily that is going to help start things. But if things are already kind of started
Happening.
and on their way, that might help. But
It was more, well, my thought was that it was more for just like all of a sudden you're going to go from like no one touching them to like a baby just
Chewing on
aggressively being on them, and then they like crack and hurt. So if you just like kind of like
Set it up.
calluses.
Callus them up ahead of time so they're ready.
Yeah, they're just like touched and played with a little bit before the baby aggressively goes after them.
With sandpaper.
I think I just want to repeat what I said before, that consent is
We're in a disclaimer on this whole
We do
episode.
need
Yeah,
it.
we need a
consent
legal
should
disclaimer.
be enthusiastic and yeah.
And then I guess my final thing was about, it's kind of in the same zone. Female masturbation, is that something that you see changing parts for the better, for the worse? Is that something that you're talking about? Because we had Jessica.
What do you
on
mean
the show.
changing parts?
Yeah, I was confused about the changing
So
parts
we had-
part of that question.
Well, like expanding them or contracting or whatever, because depending on like the age at which they start. My thing was when Jessica came on. When Jessica came on, she said that women just didn't understand their anatomy. So like part of it was like, oh, that's like a good point. But then I thought, well, like showers and these sort of things. And then there are women that get into masturbation that they would understand.
We saved the best ones for the end, I guess.
I'm still confused about the question. Where's the
so you're
shower
saying-
come in?
That was just like she was saying, like they don't even like touch the area or like, and I was like, well, wouldn't they know with like they shower and clean up? Like, and then, because when we were boys, like when you're showering and like sometimes things start getting stiffer, you're like, whoa, what's that? Like I'm just cleaning. So like I thought at some point women have the same sort of thing, but then that
I don't think so.
Yeah.
okay, and that is that good? So do you? It's not. There's nothing negative about it. Then the females are doing that.
I don't know. That's good. That's
Just when you're under the hood, I don't know if you're thinking,
That's a good question. No one's ever asked me.
You're going to need to do a TikTok on it.
Gosh, no one's ever asked me that. No, I would say probably as far as, and Jessica might have said this, but like only in general, this is not really specifically about masturbation, but in general, women are going to need clitoral stimulation to be able to have an orgasm. Like 80% of women will. So that's why it's essential to know your anatomy. But I don't know as far as like female masturbation. I don't think that's like a
pro con. There's no pros cons list in the gynecology world.
no.
Okay.
I mean, I don't think so.
Okay.
Yeah.
Sounds great.
All right, good.
All right. And so my final one is, how can we support you? What can we do to tell people about you, or where do you want everybody to go? Where do you want them? How do they reach out to you?
Yeah, I am on Instagram as Your Friend the OBGYN. I'm also on TikTok as Your Friend the OBGYN. I have a website, and then I have a newsletter. So if you go to my website, you can sign up for my newsletter. And also I have a YouTube channel that only has like one video on it.
Oh, nice.
I'm working on it.
Is it the same as all the other ones?
Yeah, it's Your Friend the OBGYN.
Yep.
I thought you meant is it the same
video.
Video? No. Okay.
Yeah.
Well, this has been so fun.
Yeah.
Thank you
Thanks
so
for
much.
having me.
All right.
Yeah.
We're here for the health of it.
For the health of it.
Just a quick note, this podcast is for informational purposes only. We're not meant to replace your doctors, and nothing here should be taken as medical advice. Always check with a qualified professional before making decisions about your health. The views and opinions expressed by our guests or hosts are their own and do not necessarily reflect those of this podcast. Reliance on any information provided is solely at your own risk.